Great, so welcome to our resource sharing meeting for August. My name is Christina Kind. I'm the program director with the Tahoe Truckee Community Foundation. And it says September. Clearly I was like jumping ahead and and not in August. So that is a typo, so sorry about that. But we do provide all our meetings with Spanish interpretation, and we do provide Spanish translation on these slides. So if you'd like to hear the meeting in Spanish, at the bottom of your screen, you should see a button that says interpretation. You'll want to click on Spanish, and then that just mutes the main broadcast channel audio and allows you to hear our interpreter, Sandra. If you don't want to hear the main broadcast channel, just mute that original audio and you'll only hear Spanish through Sandra. So I have started interpretation, so you are able to join now. And just a couple of reminders as we do these meetings in both Spanish and English, to please pause between sentences or complete thoughts. In the main broadcast channel, we can hear everyone except for Sandra. You can join the channel of your preference, and we do have live transcript, which I did not start. So let me do that. Actually, maybe it is started. And that does support both English and Spanish. Okay. Yeah, so it should be on. And if you don't want it on, you can always hide it. And just a reminder for reporting purposes, if you haven't yet this year, we'd like you to fill out our demographic form. I'm going to drop the link in the chat. And it does help us for reporting. So you can take a few minutes now or sometime during the meeting just to fill it out. It takes about 1 minute. Oop, and I'm sorry about that. There we go. So some of you are new faces and are just joining us for the first time, so welcome. We are the Community Collaborative, which is a program of the Tahoe Truckee Community Foundation. We're comprised of 46 family strengthening, health, education, and social service agencies and nonprofit organizations working together to address the fundamental needs of children, families, and all residents in the Tahoe Truckee region. Here is a list of some of our partners. If you are joining us and don't see your organization's name on here, please let me know and we'll make sure to add it. And how we work. So we work by convening. This is our monthly partner meeting. We have it the first Tuesday of every month. We work through communication. We do produce twice a month electronic bulletin that goes out on the Friday right around the 1st of the month and the 15th of the month. And so if you ever want to share any announcements or resources or updates or events or training, please email me. I'll drop my email into the chat later, Christina@ttcf.net, and we'll make sure to include it in the bulletin. We measure data, which we'll talk about a little bit later in today's meeting. We provide advocacy and capacity building. So the primary function, as I said, is to measure impact, build capacity, but also to make sure that we're a strong collaborative. And one of the ways we do that is through this meeting, through networking and resource sharing. So the goal for this meeting today is that partners are connected and informed. Here's our agenda for today. So we just went through the welcome. We're going to do a fun event next called Speed Networking. We did this at a meeting about a year ago. I think it was this meeting exactly a year ago. And so you'll get partnered with someone and we'll do rounds of 3 minutes each where you'll get to just connect, meet, share what you do. And hopefully we'll have about 15 to 20 minutes for this activity. And so you'll get to meet a few people in the room. And then we have Jonathan Lowe joining us from Tahoe Forest Hospital, where he's going to talk to us about a new treatment that they are starting at the hospital and how to extend outreach for that treatment, and it's ketamine treatment. And then we'll have a break, and then we'll come back and we're going to go through some of the data that CCTT collects. And then we'll have Ann Rarick, who's joining us a little bit later, who's going to give us an update on COAD and the FEMA assistance that's available in Nevada County. and then we'll do resource sharing around the room. And so if you're new to us, resource sharing around the room is an opportunity for you to share announcements, event training with partners. Okay. And then we have our meeting guidelines. Would someone like to volunteer to read them?
I
Thanks,
can
Cindy.
volunteer.
Oh, sorry, River, do you want to read it?
No, let Heidi go ahead. Or whoever else it was that raised their hand.
Cindy, go for it.
Bring your best self, be an active listener, be kind and generous, stay engaged.
There's more.
Oh, well, I only signed up for the first 5, just kidding. Be
Okay,
open.
River, okay. Oh,
Be open and suspend judgment, speak your truth, lean into discomfort, enable empathy and compassion, expect and accept that there may not be closure.
thank you, Cindy.
Uh-huh.
Okay, now for the fun part, speed networking. So we haven't done this.
Great. Thank you again for having me. It's nice to put some names to faces over Zoom. My name is Jonathan Lowe. I am a psychiatric provider at Tahoe Forest Hospital through the Department of Psychiatry here. I started the practice out here about 3 years ago. I've been in practice for close to 20 years and have experiences across kind of the spectrum of mental health treatment. Kiddos, adults, geriatric, serious mental illness, specializing in addictions as well. And I'm really here today to let some of the local professionals know about a new program that I spearheaded here at the hospital that is providing the first FDA-approved psychedelic medication, esketamine, brand name Spravato, for the treatment of 2 diagnoses, and we'll get into this a little bit more: treatment-resistant depression and major depressive disorder with suicidal ideation. Feel free to reach out to me, via like a private chat or a question in the group chat's fine. If something comes up and you just don't want to forget to ask the question, just go ahead and jot it down and put it in there. And I think we are good for the next slide. Okay, so just a quick high level, because I think it's important to understand, how these medications impact the brain, why we're seeing this kind of this shift in psychiatry right now. It's a very unique time to be a mental health provider, and certainly a very unique time for me in the field of psychiatry. We haven't really had a Prozac, or what we would call a Prozac moment, since Prozac, meaning that many of the treatments that have come out since then have just been versions of the same old thing without being much more effective. And now we are kind of re-exploring psychedelic treatment that showed a lot of promise, but for various reasons, the exploration did not continue. We have here, again, focusing on the one FDA-approved treatment so far, esketamine. And so the way esketamine works is it's what's called an NMDA receptor site antagonist, which is a simple way of saying it blocks NMDA receptor sites. So that's the official mechanism of action. But so what happens when we block NMDA receptor sites is that glutamate, which is our #1 excitatory neurotransmitter, it is the neurotransmitter that is reparative, restorative, it strengthens dendrites. I always tell patients it fills in the potholes on the North Shore. So now things can travel from one end to the other smoothly, safely, quickly. So when we block NMDA receptor sites, glutamate, that neurotransmitter, loves to bind to NMDA. When it can't, because we've blocked them, it has to then go to its second favorite receptor site, which is an AMPA receptor site. When this happens, it causes the brain to kind of like burst with all this glutamate activity. And that's probably theoretically what this medicine is doing and how it's benefiting our patients, or my patients. But again, the official mechanism of action is an NMDA receptor site antagonist. And I stress this because it's really important for me For professionals, I think that, everybody gets it here, but patients to understand that the brain is just an organ in the body. So all of these feelings that we're experiencing, all of these emotions that we're experiencing, problems like addiction, really what we're talking about is neurology, neurons that might not be operating as well as they could or should be. And that's where medicine can sometimes help. And we're good for the next slide.
And Jonathan, if you could just pause a little bit more between sentences, because it's
Oh yeah,
fairly
I'm so sorry.
technical material that
You're just gonna have to give me a sign because I talk, my brain works very quickly, and so does my mouth. So just, I will make an effort.
sure. Thank you. And I can give you the
Yeah,
sign.
yeah, do that.
Sure. Yeah.
Okay. So let's talk about the FDA-approved diagnosis for esketamine. It's a Schedule 3. So when you think of things like ADHD treatment, maybe like Adderall, Ritalin, that's a Schedule 2, right? This is a Schedule 3 medication. It is a controlled substance. 2 diagnoses. The one that we most often see here and get approved is for treatment-resistant depression. Now, there's no one definition for TRD. However, I think the most acceptable general rule of thumb is a patient who has major depression, who has tried and failed at least 2 antidepressants during the current depressive episode. Now, that is a very large percentage of patients. It can be as high as 30% of major depressive patients can qualify for treatment-resistant depression. And for those of you who, you might have to think back to, I think a good study to think about is the STAR-D trials, which really did a wonderful job at understanding treatment-resistant depression and depression treatment in general. So when we think about our patients, right, if I diagnose someone with major depression and I give them a prescription for an antidepressant, at best, we're looking at a coin toss, right? About a 50% chance that they are going to be able to achieve remission, which is a reduction of 50% or more in their symptoms when I try that first medicine, right? So those aren't fantastic odds, right? But where it gets really interesting is that if I have to try a second or third medication, because there's diminishing returns. So if a patient doesn't respond or has negative side effects to the first treatment, the second treatment, we're looking at probably a 31% chance that it's going to be effective for them. If we have to go and choose a third antidepressant trial, now we're looking at about 15% chance. Right. And so, for a long time in psychiatry, these have been difficult things for us to discuss with patients because we don't want them to lose hope. But if I'm giving them a treatment option that only has about a 13% chance of helping them achieve remission, that's not great. And we haven't really had much else to do other than maybe ECT or transcranial magnetic stimulation, TMS, until esketamine. So we'll talk about the rates of success here in a minute, but that treatment-resistant depressive patient. So if you're working with someone who has major depression and, within the last, let's say, year or 2 years, they've trialed a couple of antidepressants and they're just not responding well enough, treatment-resistant depression. You're looking for numbers. I use the PHQ, but any standardized tool to measure depression will help. But if we're talking about a PHQ, probably a score of 15 or more is what I'm looking for if I'm going to achieve coverage through the insurance company for my patients. And major depression with acute suicidal ideation or behavior. So this does not come with the requirement that a patient has failed 2 or more antidepressants. So this is simply for patients who have major depression and are presenting with suicidal ideation or parasuicidal or suicidal behaviors. This is a tougher one, I will say, for the clinicians out there to get your patients covered under. I often find that if I call an insurance company and say I have a patient who has major depression with acute suicidal ideation, their answer is, Jonathan, you should hang up the phone and send them to the ER. To which I always say, I thought the point was to try and keep people out of the emergency room if possible. So again, the best way I've found to treat patients with this medication so far, based on the indications, is through treatment-resistant depression. And next slide. Okay, so now we'll talk about the requirements or what's recommended for the treatment itself. The applicator, it's an intranasal applicator, right? It's a very easy to administer medication. The patients administer the medication themselves while under observation here in my recovery rooms at my office. For treatment-resistant depression, the ask, and patients, I just ask that they do the best that they can, but what we want to see is twice a week treatments that are not on consecutive days. So a patient can come Monday, Wednesday, Monday, Thursday, Monday, Friday, just not Monday, Tuesday, right? So twice per week for the first 4 weeks. This is important because patients, when they're recovering here, they have to be monitored by myself and my medical assistant for 2 hours. And that's a big commitment for patients. And then potentially another barrier is that they have to receive a ride home. They can't drive themselves home. They shouldn't operate heavy machinery until they've had 1 full night of restful sleep. Patients can go back to work as long as they know how the medication affects them and they're not performing tasks which require a high level of concentration. So if I have someone who is answering phones, like that might work. If I have a security guard who has a gun, not going to happen, right? We want them to have 1 night of restful sleep. I will say that most patients feel fully recovered in my office after about an hour to an hour and a half. The medication is in and out very quickly. So that's the first 4 weeks of treatment for TRD. Week 5 to 8, they come in once a week. And week 9 and after, it's really up to the patient based on their response, myself, and their insurance company of what they will cover. I can tell you that all the patients, every single one, there has not been an exception. After they've completed a full first starting course of treatment, the 8 weeks, every single one has decided to continue on with treatment at an interval that works for them. Sometimes that's once a week in perpetuity. I have a patient who comes in once a month, and that works for him. But I think it speaks to you know, the response rates, which again we'll get into later, about how well this treatment is being received by the patients, and again being covered by insurance, which is a huge piece for this. With major depression disorder with acute suicidal ideation, the ask is a little bit different, but again, it's rare that I get this covered. And we start off just twice a week, and we do that for 4 weeks. And then afterwards, we make the decision again, based on the patient's response, my evaluation, and what the insurance is willing to cover. And we usually start off at the top dose with that patient population, which is 84 milligrams, rather than kind of the entry level dose of 56 milligrams. And next slide. Patients who shouldn't be referred to explore this at the practice here, if they have a history of aneurysm, if they have a history of intracerebral hemorrhage, or if they have a documented or stated history of being hypersensitive to esketamine, ketamine, right? Many more providers and patients are more familiar with ketamine than they are S-ketamine. And some might say, well, I tried ketamine once, maybe even recreationally, and had a bad experience. That you would take that into heavy consideration before moving forward. Other contraindications may be, at least for the S-ketamine treatment, is if they have a history of psychosis, right? If they have a history of bipolar disorder, these are patients that probably will not be approved for treatment. And next slide. The ask is that patients don't have anything to eat 2 hours before they come in for treatment, or anything to drink before 30 minutes prior to treatment. It's not a deal breaker if they break that rule. We're just trying to keep them comfortable. And if I can keep them lying down and recovering rather than getting up to use the restroom, that's great. A common side effect is also nausea. So having an empty stomach can sometimes be helpful for patients. But if a patient is easily car sick or gets motion sickness easily, I usually just treat them with anti-nausea medication prior to them even starting treatment, and that's the fix. Again, 2-hour recovery, patient has to have a ride home. We monitor their blood pressure. That's why they're here for the 2 hours, because there can be an increase in their systolic by as much as 40 and their diastolic, that bottom number, by as much as 20. So we monitor their blood pressure minimum 3 times, once before starting the treatment, once 40 minutes into the treatment, because that's the peak, and then again before they discharge. Covered by insurance, this is the big thing, right? Because ketamine has been around a long time and has been used off-label to treat a variety of psychiatric disorders for a very long time. But it can be quite an expensive endeavor for patients. Having this medication covered by insurance is critical because it is very expensive. I would never want my patient paying out of pocket for it. But also it just increases access to a very, very helpful medication. We are getting coverage through all insurers, including our Medi-Cal, our Medicaid, insurance. Medicare also covers it. The hospital is unable to work with Medicare patients yet because Medicare only covers this medicine under their medical benefits. But more is to come on that. I know that the hospital is working hard to support more patients with the treatment. And that's the basics of that. Just know that it is well covered. Results. So we've done over 200 treatments here at Tahoe Forest Hospital. I haven't had one single patient discontinue treatment due to a negative result or a negative side effect. Every single patient has gone through their full course of treatment and then requested that we continue the treatment. The average PHQ, for those of you who are familiar with that, that questionnaire, coming in prior to starting treatment is 22.1, I believe, and that is a severe range. And current, I track all of my patients. The average patient score on this is 8. That is remarkable, right? That is a remarkable improvement, going from severe to mild, and keeping in mind that this is the hardest treatment population, right? This is the hardest population to treat. Because these are already folks who have tried and failed other medications. This isn't your typical average major depressive disorder. These are severely depressed patients with debilitating symptoms. PHQ, good question, is a patient health questionnaire. So it's a 9-item questionnaire that helps us to measure symptoms of depression and categorize them as either minimal or normal, mild, moderate, severe, and then severe. And I can just share maybe a couple of patient stories for those therapists that are out there too. I see real value in being able to provide therapy with a medication like esketamine because it is a dissociative. That's its classification. So the medicine is under the umbrella of psychedelics, but it is not a hallucinogenic, right? It is not an empathic. It is a dissociative. So patients don't experience auditory visual hallucinations. They don't, they very much remember their treatment experience. What they're able to do is dissociate a bit from their emotional brain. So when I have involved talk therapy with this medicine in the past, even though that is not required for this medicine to work, some of those experiences have been profound because the patient is able to talk about very, very deep and troubling things that are on their mind, but without the emotional attachment. It's almost like a report that they're giving the therapist. And then they retain that information and the work that's done in therapy. Again, therapy is not a requirement for this medicine to be effective. Overall, when we look at the efficacy rates of esketamine, it's 7 out of 10 patients will achieve remission, meaning a reduction of 50% of their symptoms or greater. And again, for that treatment-resistant population, that is phenomenal for any medication. So going back to the beginning of the talk, when I said, well, if you come in and I diagnose you with depression, here's Prozac, let's flip a coin to find out if it's going to work for you. So this medication is far more effective for a much more severe treatment population. And I'm excited to be able to offer it. This is the first offering of this medicine here in Truckee. And so hopefully you can maybe spread the word. Patients do not need to be a patient of my practice in order to receive this treatment. So I see patients for consults all the time that I do not see, and I do not manage their psychiatric medicines. They see other providers. That's fine. Patients can be booked through my practice for a half-hour consult, and just kind of being familiar with the treatment will help to make sure that the right patients are being referred to the practice, so I don't give them, the bad news that they don't meet the criteria, or that they have a rule out, say they have a history of aneurysm. And I'm happy to answer any questions.
Thanks, Jonathan. So we have about 7 minutes for questions. Devin, I see your hand up, but Jonathan reached out because this is a new treatment. And so we thought it was a good idea to bring it here just so people have the opportunity to ask questions, kind of dispel any myths that are around this type of treatment. And then Jonathan also asked for some thought partnership and how to extend outreach. So I'll let Devin go, and then Christine, and then feel free to raise your hand using the Zoom function or just raise your hand the old-fashioned way.
So Lizzie, yes, Dr. Koch at the Incline Village practice does offer esketamine treatment as well. Although I believe her practice, because she's a very busy primary care provider, is much more limited into how much time she can spend helping, making sure that the patients have the space to recover. But that is an option. Ketamine and esketamine, what is the difference? All right, so esketamine is basically like a mirror version of ketamine, which it allows us, or the structure of esketamine means that it has a greater affinity to cause that antagonism with the NMDA receptor sites. So we're able to give this intranasally at lower doses for theoretically a stronger effect that we're looking for in the brain. And this cuts back on potential negative side effects. There's 4 years of data now on treatment, patients who've continued treatment for 4 years. And the exciting news is that there's no long-term negative side effects. The negative side effects that I was discussing earlier, like nausea or dissociation or sedation, those occur while patients are here in recovery. They don't follow them into the community. Unlike other medications I prescribe that sometimes come with chronic side effects for patients, these side effects are very much acute. And another good element to S-ketamine is that it is not showing any cognitive decline in patients, where you do see that with high dose ketamine use, especially if ketamine is being abused, it can cause cognitive problems for some patients. Under 18, can it be administered? No. So again, when you're thinking about patients that don't meet the narrow kind of treatment requirement for S-ketamine currently, that will change. This will broaden over time. This is a new medicine. Then you're looking, for patients who might be better served by a ketamine clinic who can operate outside of the one FDA-approved diagnosis for the use of ketamine, which is for pain. So ketamine clinics, they can work with patients in different ways than I can.
And Jonathan, Devin had his hand up before. Devin, do you still have a question?
No, I was just curious the difference between ketamine and S-ketamine, and if someone, I guess, didn't qualify for insurance through your clinic, would you suggest they seek out a ketamine clinic? Would you go to the regular antidepressant route? Like, what does that look like? And I guess there's a few ketamine clinics in our community as well. So just curious. Great presentation too. Thank you.
Oh, thanks. So yeah, we have one ketamine clinic here in Truckee, Kensho Center, run by Cody, and they can provide intravenous as well as lozenge forms and IM ketamine for various purposes. Again, everything is going to be cash with ketamine because it's going to be used off-label. There's also services that are popping up online, things like Mind Bloom, where they will actually mail the product lozenges to the person's home. So if I have a patient who has means and they don't qualify for S-ketamine treatment or their insurance won't cover it, my suggestion is to look at that route. There's Radiance Clinic in Reno, there's Thunder Pain Management. There's a few clinics that can offer this service. And because it's much cheaper. Ketamine is a very inexpensive drug made by compounding pharmacies, whereas S-ketamine, if someone wanted to pay cash in hand, would run about $800 to $1,100 per treatment, and that is just too much. But covered under insurance, my patients are often not paying anything, or they might pay $10.
And then before we get to the question in the chat, I know Christine, you had your hand up. Do you still have a question? No, okay. Then we can get to the question in the chat. Victoria is asking, can you speak a little bit about what the patient feels like during treatment?
Yeah, every single one of my patients, they're always nervous coming in because they don't know what to expect. And 201, every single one of my patients has left or experienced just a feeling of like giggly and floaty. So I go and check in on them, and they're smiley and they're happy, and they feel as if they have reached a transcendent meditative space, that they, sometimes they kind of float away from their body. But this has not been an unpleasant experience. I think when we think as ketamine, oftentimes we think about the unpleasant experiences of ketamine being used in an ER. However, we need to remember that ketamine is being used in an ER because someone's there with a broken bone or they're in extreme pain. It's a very different experience. And set and setting, the setting where we are receiving the treatment and the mindset going in have a huge impact. And we're using S-ketamine for very different purposes at the hospital than we would use ketamine.
Are there any other questions for Jonathan? And then Jonathan, do you have any questions for our group? We are a group of community-based organizations. We have some of our county partners here, some of our partners from the hospital. And so if you have anything you want to ask of us.
Well, I'm hoping I can be invited back if I've earned a slot. It's just nice to, again, meet some of the community leaders here. I think my question here is, I'm new, to the area. I moved out here in March of 2020, right when everything shut down. So I'm really just been starting to kind of explore other practices here in the past couple of years. So there's a lot I still don't know. One of the things that I've noticed here at my practice is that my patient population does not match the general population of Truckee. I am not getting a fair balance of patients here at the hospital practice. And I am very, very interested to know ways that we all might be able to work together to make sure that information gets out to every potential patient, regardless of what language they speak, and making sure that it's done in a way that it will be received. And I just want access for all. That's what I enjoy about the esketamine so far, is that coverage through Medi-Cal and Medicare is critical. I just want to make sure that those patients are, that I'm able to connect with them, and I'm sure that you all will be a huge piece of that. And just thank you for everything that all of you do.
Thank you, Jonathan. And Jonathan, you can feel free to send me anything you want moving forward that we can send out to partners if that's useful, or we can include in the we do a twice a month electronic newsletter that we can put like trainings in or announcements in. And if you're able to join us, we host these partner meetings the first Tuesday of every month. And hopefully you got to meet a few of the partners and speed networking, but we definitely have a good mix of partners here from all sectors.
Perfect. Thank you. And then just a shout out for Coco for inviting me and letting me and helping me to be aware of what's going on. So nice meeting you all. I have to go see a patient, but feel free to reach out to me at the hospital. If you have any questions privately, just give me a call.
Great. Thanks, Jonathan.
Take care. Bye.
You too. So we will take a 5-minute break, and then when we come back from break, Ann Rarick will talk to us about COAD and FEMA assistance, and then we'll dive into the report card. It's really just a way to kind of show you all where you can access some of our regional data, and then we'll have time for resource sharing. So we'll see you guys back here at 11:07. We've invited Ann Rarick from the COAD to join us. And to just give us an update on FEMA assistance in Nevada County. So Ann, if you're okay, I'll present your slides. I just combined them all, the English and Spanish on one slide.
Yeah, hi everybody. Thanks for having me. I'm Ann Rarick. I am the Tahoe Truckee COAD manager. COAD stands for Community Organizations Active in Disaster. Wanted to give an update. We can go to the next slide. So Nevada County, so only Nevada County, this doesn't apply to Placer or Washoe counties, but Nevada County was included in the federal disaster declaration for the winter storms that occurred in February and March of 2023. So I wanted to give an update on how you can access assistance. So let me back up a little bit. When we're included in that declaration, we were included for individual assistance, which means anybody who experienced damages due to the storms can apply for FEMA assistance for that family or individual, which is a little different from public assistance, which means like the towns and the counties are working to get reimbursement for damages. So it is helpful for folks. The FEMA and the counties and California Office of Emergency Services set up some local assistance centers. So that was the event that was happening at Alder Creek Middle School. Those centers have now been shut down, but the application deadline was extended till September 1st. So we really want to get the message out there that you can still apply. So these are some ways to apply. You can go online, call the hotline, which is up here, and apparently FEMA has an app. So also want to kind of preface this, I'm not an expert in FEMA. I've been trying to learn the different programming. It is a little complicated. So really want to encourage folks to just get their applications started. There are quite a few eligibility criteria. So if we can go to the next slide, Christina. There are some reasons for denials of FEMA claims. FEMA really encourages people to go through insurance first. That's your first step. So you have to make an insurance claim, which is we've kind of talking to some folks over at the local assistance center. We know that, you know, it's a concern to make claims because people are worried about their insurance dropping them. So that is a really real concern in the community. Unfortunately, FEMA is going to kind of, you have to apply for it. You have to make your insurance claim first. It does have to have a significant amount of damage, usually a percentage of what the home is worth. And the home needs to be a primary residence. So this doesn't apply to second homeowners. It doesn't also apply to certain things like carports, decks, fences. They kind of have a whole list of things that criteria and things that are included or not. So a significant number of FEMA claims get denied, and so FEMA also encourages folks to reapply. A lot of times the paperwork can be confusing, or there's a, you know, missed a certain thing here or there. So they do encourage people to like renegate the claim if you get denied. So it's kind of all I have. We can send out the graphic that showed how to apply, but if you can just encourage people you're working with, if they had damages due to the storms, give them the information. Also, we have been working, the COAD has been working with our voluntary agency liaison, which is a position through FEMA, to kind of see if there's the need to stand up a long-term recovery group. So if you are seeing needs on the ground with your community members, the people you're working with, please let me know. My contact information is on this next slide. And then I can bring back those needs that we're seeing to FEMA, to California OES, and say, hey, there's this whole group of folks that are, you know, but if we don't know what the needs are, we can't really advocate on behalf of the state and the feds. So I encourage you to bring that up to me and shoot me an email, and we can make sure that we are reporting those needs.
Thanks, Anne. Thanks for your advocacy efforts too. Does anybody have any questions for Anne? Okay, and then we'll send the slide deck out after this meeting, so we'll have the information on how to contact FEMA, and then we have been including it in the bulletin, so I can make sure to send out those links as well for just more information on what is covered, and then we'll move on. Thanks so much, Anne.
Yeah, absolutely.
So the next topic that I wanted to cover is our report card. So some of you were able to join us in May. And some of you may have seen the recording, but Allison gave a presentation on data for our annual, or it's not our annual, but we have been doing a report card for the past 15 years. The last report card that we did was in 2019. We did update the data recently, and Allison presented that at Good Morning Truckee on May 16th. Ian joined us and gave us an update on COAD. Teresa joined us and gave us some data from the Sierra Community House. And then we had Kim Bradley and Kirsten Kramer and Logan Maloney from the school district to talk about education data. So it's a really useful recording, especially if you're using data for any of your grant writing or just to define some of your programs better. You know, I definitely recommend that you watch the recording. I'll drop a link into the chat box at the end so you can watch it, and then we'll put it in the notes as well. And so, as I said, you know, we've been doing these report cards for the past 15 years. The last one was in 2019. We did provide it in Spanish, and I couldn't find a graphic of that in Spanish, but we do have it available in Spanish, and we are working on the next iteration. And the measures that we measure are based on the social determinants of health. which is education, healthcare, your built environment, your social context, and then economic well-being. And we really break it down into just 3 categories: economic well-being, health, and education. And we pull data from over 12 resources, primarily secondary resources, which are listed here. They don't look like hyperlinks, but these are all hyperlinked. So I'll send this out afterwards, and you can pull directly from the different reports that we've been pulling from. And then in a minute, I'll show you like where all this data lives, but I just wanted to remind people of where we're primarily collecting data within the TTUSD boundaries. Some of the data that we pull, especially from the hospital, is outside of this boundary, but for the most part, we're primarily just measuring within the boundary. And Sandra, I'm sorry, I realized I was talking really fast. And so I'm going to show you in a moment what our scorecards look like, but what we are trying to measure is the indicator, but more than just the indicator. And why we bring it to you guys is because we want to get the stories behind the data. So what does the indicator actually measure, and what is the story behind the curve? And I present this data point to you. It's something that some of you may have seen. It's from Mountain Housing Council from their recent regional housing implementation plan. This was done in 2021, and it found that we have an inadequate housing need of 9,528 units in the region. And so that's something that we just throw out. But if you're not in housing or you're not in these meetings, you may not understand what that means. And so when we're talking about the report card and we're talking about the issue brief, we really are trying to understand what is the story behind the curve and dig a little bit deeper and dig in deeper with you as our community partners. And so when we look at this data, we know that inadequately housed needs means that people are either overburdened, so they're spending more than 30% of their housing costs or of their income on housing costs, or they're living in overcrowded situations where it's more than one person per room, or inadequate housing, which doesn't have plumbing or kitchen facilities. And then we can even dig in a little bit deeper and see like, well, where in our community is this happening? You know, who is primarily affected by this? Is it younger people? Is it older people? And then we can dig even deeper and talk about what programs are kind of helping to move this curve. And so we are going to spend the next 6 months digging deeper into the data and digging deeper by each area. So health, education, and economic well-being. So I wanted to, before we dig deeper, I'm going to give you the schedule, but I wanted you to also be able to know where to access this data on our website. So if you go to our website, which the Community Collaborative of Tahoe Truckee is a program of the Tahoe Truckee Community Foundation. So you'll need to go to the Tahoe Truckee Community Foundation's website first, which is just ttcf.net. And then you'll want to go to our initiatives and scroll down to the Community Collaborative, which will bring you to this page. And this page is just useful to have anyway, because it gives all of our meeting recaps. So you can find our meeting slides and meeting recordings from all of these resource sharing meetings. And then it gives you our data. So if you go to the furthest tab, it's community data. And then again, we're tracking indicators in 3 different areas. And my computer's a little slow, so I pulled up one already. So mental health. So you can pull, I thought this would just load because I already had it, so I'm sorry. But so you can go back to this page and you can click on learn more, and it'll give you the actual data, and then it'll give you an issue brief. And so we've updated the actual data here on the website, and what we're going to be working on next is putting it into a 1-page document that's easy to understand as an issue brief. And that's where we want to also rely on you guys for some of the stories behind the data in that issue brief. So the issue brief that you'll find on the website is from 2019, but you'll see that the data has been updated where we can update data. And so we measure data in what we call a results accountable framework. And we measure it by the results we want to see and the indicators that we want to track under it. And so we'll dive deeper into this again over the next 6 months. But what you can do is if you want to see like what is the percentage of TTUSD kindergartners with required immunizations, you can click on this indicator and it will tell you what the indicator is, the story behind the indicator, and then you can actually see the data. And some of the data goes back pretty far, so you just have to adjust it on your screen. So this one goes back all the way to 2006. And so it's measuring the percentage of kindergartners, but it also disaggregates based on socioeconomically disadvantaged. And it shows you the state total. So it can be kind of a lot on this map. And so if you just want to see one, you can just turn them off by clicking on them. So that now you're just seeing the California percentage. And if you just want to see the TTUSD percentage, oops, you'll just want to click those off. And now you're just seeing the TTUSD indicator. And then if some of you don't like seeing it in a bar, you can change here and see it in the line. But so this is just for you guys to kind of play around and start to get familiar with the data. And then over the next few weeks, we will be digging deeper into it. And I wanted to give you guys the schedule. So in September, we'll be talking about health data. We'll have representatives from the hospital coming and we'll go at a much slower pace. And then we'll do some breakout groups around some of the data points. In October, we'll be talking about the economic well-being and really focusing on a lot of the housing data that we have. The Mountain Housing Council did a needs assessment in 2021 and just updated it. And we should have the final results of that within the next 2 weeks. So we'll have fresh 2023 data there. And then if you've been attending these meetings for a while, you know that in November, we have our annual youth forum. So we will have that again this year, our annual holiday party in December, and then we'll return back to data in January with the school district. And that meeting doesn't fall on a regular Tuesday because that's still during winter break. So we'll be the second Tuesday of the month in January. So it'll be January 9th. And I know that was really fast and I can see some like quizzical looks on your face, but I just wanted to be able to give you the link to the video so that you can see Allison's presentation, show you where you can find where some of this data lives on the website. A lot of the data that you see on the website is trendline data. So some of the data points that Allison talks about in the video aren't on our website because they're just one point in time. So we don't tend to include them in the scorecard until we have at least 3 data points, 3 points in time. So some of it you won't see there. And then because all of you have so much free time, if you want to take a look around and you don't see any of the data and you want to really see what's been trending, let me know and we can probably find it. We're sitting in a lot of data here. And I just also wanted to share, there's a couple other sources you can go to. Like we only share a couple points from the California Healthy Kids Survey, which is a survey done every 2 years through the school. But there's a great dashboard online that you can view trendline data on. And so I've pulled it up here. This is for TTUSD, and you can see trends over time by just clicking here. And so this is really helpful if you're interested in any of the California Healthy Kids data. CCTT has done a behavioral health survey. We did it in 2020 and in 2022, and we have that data on this dashboard. So again, I'll provide you all these links afterwards, but there's lots of places to go to see the data. And so I know that was a lot. Does anybody have any questions? Okay. Okay, well, I'm looking forward to digging deeper into it and looking forward with starting with health in September. And so again, we want this to be a really interactive process. So it's going to be a lot of breakouts and we're just going to dive a lot deeper into it. And we have a ton of data, as you can see. I mean, just this dashboard alone is on behavioral health. And then we have the reports done by the hospital. And then we're also pulling from census and from a few different other areas. Okay, all right. Well, then we will move on to resource sharing. Yep. I have a couple announcements I put here in a slide so that I wouldn't forget. And I saw that Candace is on as a participant. So Candace, if you want to pop in here and give an update, you can, but they wanted me to share, and let me just read it so that I share it correctly. That the Sierra Nevada Regional Department of Child Support Services, in collaboration with Sierra Community House, would like to announce monthly clinics where a child support representative will be available to answer any questions that you might have. If you have a child support case-specific information can be provided to you. If you want to know about child support, general information about child support and available services can be provided. Spanish-speaking representatives are available on site. These clinics are held the second Wednesday of each month from 9:30 a.m. to 3:30 p.m. at Sierra Community House in Truckee. And Candace, did you want to add anything? And I can make these flyers available after the meeting.
I think that pretty much covered it. And thank you for inviting me to the meeting. It's been really nice getting to meet some of you. One additional thing. So the plan is to go monthly. However, during the snow months, it may be by appointment and weather permitting. So.
Okay, thank you. And then I also wanted to make an announcement that September is Suicide Prevention Month. And so in partnership with the Suicide Prevention Coalition, we are planning for a personal safety plan talk, much like the one that Shannon, who's on the call, so I'll let her jump in here, did at our resource sharing meeting in May. However, this one we're planning to do on Zoom. And so I just wanted to have you save the date. And then Shannon, if you want to add a little bit more about the presentation, please do.
Yeah, we are going to be focusing on starting conversations with folks that you are picking up signs are struggling, or you have direct information that they're struggling. Safety planning traditionally is something that occurs in a healthcare setting, but it doesn't have to. It can be something that we do upstream. And so since we met in May, if you were in attendance, I found some additional resources aside from just this safety planning tool for using this concept, these conversations, starters, these questions, to build a personal safety plan before a person's in crisis. So it'll be a 1-hour training, and we will focus on some of the signs of suicide, but we're also looking at this as an upstream de-escalation planning opportunity. So I hope you'll join us.
Thanks, Shannon. And I was actually away at a conference in May, so I didn't get to join, but I heard really good things about the training. So if you didn't go, I highly recommend that you join us in September. And then the last one for my announcements, I'll open it up to everyone else, is that there are a few really important housing meetings coming up, one being today on Zoom. It's for the Tahoe Basin Area Plan amendments. If you've been following it, it's been fairly, I don't want to say heated, but it's been very well attended, the previous meetings. And so this meeting will give you some updates, especially since the last meeting in December. They have done some rework, incorporating community feedback, but these are really important amendments that a lot of people believe will get more housing for the workforce in the region. And so I suggest that you attend tonight if you can at 5:30 on Zoom. And then these amendments will be going to the Planning Commission Thursday, August 10th at 11 a.m. And that meeting will actually be in person at the North Tahoe Event Center. And then the Truckee Chamber of Commerce is hosting a lunch and learn on August 9th from 12 to 1 in person at the Truckee Town Hall Council Chambers on their Truckee Home Access Program, which if you haven't heard about it yet, it is a program that is helping people purchase homes. So they'll give you up to 15% or $150,000 towards a home purchase in exchange for a deed restriction. And the idea is that by having homes are deed restricted, we create a second market of more affordable homes for the workforce. And it's for the workforce. The deed restriction does stay with the property. It's a 55-year deed restriction, and you have to be an employee within the TTUSC boundary. And there's some criteria on their website, but they've been doing a bunch of workshops. They have all the materials in Spanish. They've even done a Spanish workshop, and you don't have to be just a home buyer to take advantage of the program. It's also for people who have homes who may want to deed restrict them. And they're also working with employers and developers. So it's a really good program if you want to learn more about it. Attend the Truckee Town Hall on August 9th. And that is it for my announcements. If you have an announcement, please raise your hand and I'll go in order of the hands that I see.